thank you all for giving me the opportunity to present again today. I see some familiar faces in the audience, and so I want to say that on the one hand, some of this may be repetitive. On the other, if there's a question that comes up or something that you didn't get a chance to ask before, or if you just have a question and you're new to this group, please interrupt me. I really prefer to have an ongoing dialogue in a learning mode rather than just me talking to you. So I'm going to try and cover an enormous amount of material because they've given me so much time to talk. And I've got endless things to say, but I don't intend to necessarily cover everything that I have on the slides, just because if there's some sidewinder or some other topic that comes up, please bring it up and we'll talk about it. Okay, so we'll start with a quiz just to wake you up because it is morning and it's always nice to sort of take your pencil and jot down your responses to these questions. Question number 1, true or false, 1 in 50 people in the USA will have epilepsy in their lifetime. 1 in 50. True or false? Question 2, febrile seizures are a form of epilepsy. True or false? These are all true or false. 3, epilepsy surgery can be done even in infants and young children. 4, there's a high rate of depression and anxiety associated with epilepsy. And 5, epilepsy is most often genetic. And just to make a distinction early on that confused me for many years and probably confuses many people still, just because something's genetic doesn't necessarily mean it's inherited, because a lot of genetic events occur in the individual. So something can be genetic, but doesn't have to be familial or inherited. Okay, so we'll get back to those at the end. So what I hope to answer for you today or touch upon are a few basic questions. What is a seizure? What is epilepsy? Who gets it and why? And how is it treated? So kind of the simple overview of epilepsy such as it is and what do we do about it? Or what are the options? And so going back to where we're talking about, this is the brain, the human brain, and it is a most marvelous organ. It is the most complex and complicated organ known to man in the body. And as you can see, it's made up of a number of folds, and its surface is crinkly because the cells that line the surface are all folded in humps and valleys, and that allows it to have an incredible surface area. If you stretched it out into one cell thickness deep and just sort of one layer, it would be well over the size of a football field. So you can imagine what's packed into that brain. Billions of cells, billions of neurons that are aligned and adjusted with each other in a way that makes it work. And you can imagine there's a lot that can go wrong with that because it has to be precisely constructed and hooked up within itself. So we divide the anatomic brain into lobes when we talk about it, and you can see in purple the frontal lobe, which is the biggest lobe, and it's really pretty much from just in front of your ears forward. It's the massive part that distinguishes humans from other brains, really, of animals. Our frontal lobes are very developed. The temporal lobe in light blue comes down behind your ear. The parietal lobe in green up and sort of high but getting posterior. Way in the back in dark blue, the occipital lobe, and that's the site of vision. The visual cortex is in the occipital lobe. So it's way back here that your eye fibers and nerves have to run to get to for you to see. The little red brain called the cerebellum, the little brain, sits kind of down and behind. That's your gyroscope. That's your real central mechanism for balance and coordination of movement in a fluid way. And then in front of the cerebellum is the pons and the medulla. Those are the brain stem structures that you can see in this view. If you cut the brain away, the brain stem goes right up into the brain and has what we call the deep basal ganglia, which are masses of gray tissue, masses of neurons that really, again, are way stations for the motor system primarily, smoothing movement and making it precise. So just a quick joke for the morning. Well, that was a good one. Try it out. Just poke his brain right where my finger. We don't really do that in the OR. But anyway, this is the working cell of the brain, the neuron. And neurons are, as I said, there's billions of them. They make up what we call the gray matter of the brain. And the white matter of the brain is their process, which you can see with the yellow blobs around it, is called myelin, those little sheaths that surround the process of the nerve called the axon. So the neuron, the cell body, has a long stringy process that is covered with myelin, white matter, that allows for it to transmit its impulses, its electrical impulses, right on down in a fast way, and there's no leakage. So it's sort of an insulated wire. When you're born, you really don't have that insulation, so babies aren't able to really coordinate or do things in a real directed way. But as they develop, you start to see them myelinate, and you start to see them be able to sit, stand, walk, talk, and do all the functions that they can do. So the myelination allows for very directed activity of the brain cells. The neuron, as I said, has a lot of little funny things sticking off of it, like antennae, and those antennae are actually the receiving end for the neuron from other neurons. And there's a bunch of busy connections. The axon, the long string process, goes down and then splays into many, many connections with many other neurons. So you can see that directed traffic of electrical activity is really pretty closely controlled, but also there's a lot of possibilities in terms of where it can go. And this is just a cartoon to show that at birth on the left, your neurons are relatively free-floating. They don't have a lot of connections. The black sort of spidery tree-like things are neurons. And when you're 7 years old, there's gazillions of connections. The neurons make tons of connections. And between 7 and 15, actually the connections are reduced through a process called pruning. So you kind of make all these connections, and then you use your brain, and the brain decides, okay, we're going to keep this connection, but we're going to let that one wither away and not have it happen. So you can imagine these connections being made in a child who has epilepsy, where there's unusual brain activity, unusual things that aren't supposed to be happening that would affect this process. And the direct correlate of that might be, say, development. Because if there's abnormal brain activity, that is the same activity that makes connections normally, but it's in the wrong place at the wrong time, so it might make different connections. And this is an actual human neuron. There's 3 of them there, but you can just see the incredible connections that they have. So if you take billions of these cells and give each of them thousands of connections, it's beyond the New Hampshire lottery in terms of the chances of figuring it out. Okay. And then we've got modern techniques to look at brains, and this is just a cartoon of Homer Simpson's brain sitting up there in the cavity. So what is epilepsy? And just so you know, the definition of a seizure is uncontrolled hypersynchronous, meaning too many neurons working together at the same time. They're usually very carefully controlled in terms of their activity, but if a bunch of them start to beat the drums together, that's hypersynchrony. That's danger zone for seizure. So excessive neuronal behavior, so an electrical brainstorm. So seizures definitely happen, and epilepsy exists, but there are so many different kinds. How do you figure it out? So really, anything the brain can do can, if it's in excess, manifest as a seizure. So just the simple movement that you do to bring the cup to your mouth might be a movement that hyperexcitable brain cells would provoke, and you might do it repetitively, and that might be a seizure manifestation. So anything the brain can do, including thought, can be manifested as a seizure. We classify seizures in a pretty direct way according to what you see out here in the real world. And seizure classification, seizure definition is something anyone can do and hopefully will do, because as a neurologist, I rarely actually get to see the seizures as much as parents with children who have seizures do. So we classify them according to whether they're part of the body or all of the body, partial or generalized. If it's part of the body or part of the person, that implies that they're somehow maintaining a little bit of alertness, maintaining a little bit of interactiveness capability. And if they're generalized, it implies that they are unresponsive. All of them is missing from the picture. As far as the motor system goes, a partial seizure would be part of your body, so twitching of a hand or twitching of a face. And a generalized one would involve all of your body. But just keep in mind that generalized can include behavioral arrest. So a generalized absence seizure may not be manifest by any movements at all, but rather a cessation of movement, a sort of paralysis of movement, and just staring unresponsive. That's still generalized because it's the whole person involved. So within the partials, we talk about simple partial, and that means it's just no involvement of your consciousness. Just your leg is twitching, your face is twitching, something is not right, but you're able to talk about it, you're aware of it. Complex partial is used as a term when it's part of you, but also you're a little cloudy, misty, you might not be responsive. So during a complex partial seizure, a person might look at you when you ask them what their name is or call their name, but they might only be able to grunt or just kind of look at you, but they won't be able to respond and appropriately. Either the simple partial or the complex partial can secondarily generalize. So you got this little seizure happening in part of your brain, and that can propagate and include more and more parts of the brain and spread to involve the whole brain and become a generalized seizure. So many partial seizures will start off partial and end up generalized. And that's often when you'll hear the thump in the bed at night, or you'll go in and find a child having a seizure, and you won't have seen the simple partial or the complex partial part of it because it might be pretty quiet. And so you'll describe to me, oh, she had a generalized tonic-clonic seizure. And then we do an EEG, and there's a focal area, and you suspect, well, maybe it started off in that spot. Okay, so again, simple partial seizures are depending on which part of the brain is getting activated and being hypersynchronous, you'll see different manifestations. And this cartoon by Netter really can show you some of the different ways, depending on which part of the brain it comes from. In the pink and blue strips, that's the primary motor and sensory strip of the brain. That's where the big cells that are configuring your body on the opposite side are, and the sensory cells as well. And so if it comes from one of those strips, you can have a primary motor seizure, clonic jerking of an arm or twitching of a face or a leg, or a hemibody. And if it comes from the sensory, you would probably have a paresthesia, a sense of tingling, or some kind of numbness, or just a different sensation of feeling on that side of the opposite side of the body. If it comes from somewhere in the sort of down under the frontal lobe, you can see over here at the bottom right autonomic manifestations, which would be sweating, a feeling of hypoglycemia, maybe you could call it, as the manifestation. And then if it comes from the temporal lobe down at the lower left, if it's in the auditory cortex, the part of your brain that hears things, you might hear clanging, ringing, voices. Hallucination type of experiences can be a seizure depending on which part of the brain they're from. And if it's from the occipital lobe, way in the back of the brain, you might have a visual hallucination. So you might see spots or unformed colors, something like that. And that may be the limit of the seizure, or it may secondarily generalize, in which case you might have a full-blown seizure following it that everybody would recognize as a seizure. In the middle at the bottom is an EEG, and I'll get to EEG in a bit, but this is one of the ways that we really certainly evaluate seizures and tendency risk of seizures based on the EEG. And in this case, just remember the EEG showing those spikes, those guys, is a partial or a focal phenomenon in this case. Complex partial seizures are, again, a step up. They are partial, but they involve clouding of your consciousness or some misty feeling, often a deja vu or a feeling of just not being quite right, things are off, unsettled, panic, and not fully responsive when someone might call your name. And those are classically coming from the temporal lobe, which is the way station for a lot of emotions and also some of the rising feeling of nausea, vomiting at times, so some of the autonomic symptoms too. And complex partial seizures are, again, depending on where they come from, often associated with what we call an aura, which is a warning that the seizure is coming. A person will experience some odd feeling or some odd perceptual shift that happens moments before the seizure comes on and moments before they kind of go under and become less responsive or unresponsive, and moments before the seizure may get out of the barn and become generalized. But this is classically associated with an aura that the person might remember. They might say, yeah, I always get this feeling and I know it's coming based on that. So if you know now about seizures and how they're classified, how do people get them? And this is a pie chart just showing the distribution. And if you go across the midline, you can see that about half of seizures are going to be partial, complex, or simple, and about half are going to be generalized. And you can sort of distribute them across the boards in terms of what people experience. This does not include secondarily generalized seizures, which do occur a fair bit. And so if you know about seizures and you know about how they occur and how they're classified, then you know epilepsy is just a series of unprovoked seizures. And epilepsy is in turn classified. The scheme for classifying epilepsy is a little less easy and it's a little more complicated because we throw in features like what does the EEG show, what are the genetics of this known type of epilepsy, what age does it happen, what is the prognosis, what are the meds that it might best respond to, and kind of hang clothes on the skeletal underpinnings of the seizure disorder. So epilepsy is classified into this, and it's undergoing reclassification right now, and so it's going to completely change, so don't bother learning this. But it's kind of in the same sense of what we call symptomatic or acquired versus idiopathic or genetic. So we tease apart the epilepsies into the two worlds of, is this a standard classic epilepsy known, many other kids have it, we know the genetics of it, the EEG pattern is typical, or is this something that occurred as a result of a head injury or an early life infection or some other sort of cause that we call symptomatic epilepsy. It's a symptom of something that's happened to your nervous system. That's the big divider between the epilepsies. And because some people certainly acquire their epilepsy not by a genetic basis, although there may be a predisposition, but they acquire it after a car accident or some kind of an injury. And then the majority are going to be genetic and inherited, or at least genetic. So this is how epilepsies are classified. And so how big of a problem is it anyway? Because it is certainly prevalent. And just a few facts about epilepsy. It affects 2% of the population, which, you say, well, that's 98% aren't affected, but 2% is a huge number. It's, I think, the third most, either second or third most common neurologic disorder in the world. So it's really common. And not that you remember the quiz beforehand, but I'll get to a fact that will surprise you as much as it surprises me, that 1 in 26 people in the United States will have epilepsy in their lifetime. So it's really common. 90% of it occurs before you turn 20. So it's a pediatric condition in large part. Neonates account for a huge percentage of kids who have seizures. And then a lot of the genetic epilepsies start during childhood. And then another big chunk of them start in puberty and adolescence when you're going through the turmoil of growth and change. Febrile seizures, which are very, very common and affect up to 5% of children, are not considered epilepsy. They are considered a symptomatic expression of an age-related susceptibility. So a symptomatic expression of an age-related susceptibility. And that is to say that it only affects children, they outgrow their tendency, and it's not considered epilepsy because there's always some kind of a fever or illness involved provoking it. so they're not spontaneous seizures unprovoked, if you remember from the definition. It still shows up on the table of epilepsy classification, though, for some odd reason. And again, mostly epilepsy is considered to be genetic in that it's either direct gene and epilepsy, or more likely and more often, it's susceptibility factors that are in your genes so that your brain has a slightly lower seizure threshold than someone else's. And so given the right circumstances, you may have a seizure.
Can I ask a question?
Yes.
Does that mean that you can find it through genetic testing always or not?
That's a really good question. Can you find it through genetic testing or not? And some of them, yes, but very few. Most epilepsies are not yet worked out in terms of the genetics. I think the Human Genome Project that's been going on includes one branch looking at early life epileptic encephalopathies, so babies with infantile spasms and children with severe epilepsy, and they have found about 12 or 15 genes so far and counting in terms of punching through many, many more sites. And they're finding surprising things in terms of what leads a person to have epilepsy. So I think eventually when the Human Genome Project and the whole exome sequencing, which is what's being done now for genetic testing, gets fully cataloged, we're going to probably find a huge percentage. But if you came into the office today, there's a small number that we can actually send a blood test to say, you've got that. So another interesting and important fact is that no matter what medicine, and we've got 15 or more now, no matter what medicine you use, a third of people will be medically refractory. They will not respond to medication. That's a lot of people, and this has been confirmed in study after study. So again, the medically refractory epilepsy is the most challenging because that's the mainstay of therapy for people with epilepsy. And about 30% of the 30%, so now you're down to a ninth of people, may be surgical candidates if they are medically refractory. That's the pool from which the surgical epilepsy patients come, because you don't go to surgery if medications work. Yes?
So the patient's medically refractory and they're given a bunch of medication. How do you know whether anything is working? Because you probably wouldn't want to take them off.
Yeah, well,
like adding.
Yeah. Well, I wish you could come work with me. And the question being, how do you know if a person's on a whole bunch of medications, if they're doing anything or not? Sometimes we do have drug holidays when it gets to the point where you're on 5 or 6 meds and you're having the same number of seizures as you had before. In terms of the literature, if you go on one medication and fail, you go on 2 medications and fail, the field has moved towards saying you're refractory and not waiting 10, 20 years to figure it out, but saying if you failed 2 medications, you should be looked at for surgical candidacy. Or for alternative approaches to treatment, if you haven't tried them. There are some savvy ways of looking at rational polypharmacy or rational pharmacology where you say, okay, this med affects that channel, and this med affects that one, and this one does this. Let's try this combination. And you can shave another 5 or 10% maximum off of that group who are refractory. But for the most part, if you fail 2 medications, you're in that group. And, it's pretty much a done deal that you're not going to respond to another medication.
So does failing mean take the medication and then the seizures, what if they get less than they were?
Yeah, well, I think that's that's another good point. I think the goal of therapy is complete control of seizures and to not have any. So if you put that as your bar, and that's what you expect from your medications or other management, then a partial response doesn't really count as an adequate response. Because if you have 1 seizure a month versus 5, well, you still have 1 seizure a month, and when it comes time to drive or whatever, it still can be disabling. On the other hand, in the real world, knowing that only a third of the third are going to be surgical candidates, it's as good as it gets to say, okay, we've got them down to 1 a month, and your child isn't toxic or is able to take the medicine. So certainly, in the real world, you take what you get in a lot of cases. I mean, it's far from perfect. So I'm talking more theoretically that we try to go as get seizure control in for you. Okay, so this is a pie chart just, again, showing from a study, and this study's been reproduced many, many times, so the numbers seem to hold true across the boards, that if you take medicine, this is unfiltered, this is all people with epilepsy coming into an outpatient clinic, 500-some patients, so it's not by type or anything else, and certainly that breaks it down. But just across the boards, about half of people will be responsive to the first medication that they're given, and it will control their epilepsy, and that's the end of the story. So that's the great group to be in. If you have to go to a second medication, you get about 13% more yield. Third, 4%, point of diminishing returns is reached pretty rapidly, and then you have that third of patients who don't respond to any combination or any number of medications. So in pediatrics, as you know, most epilepsy begins in children. We get the best and the worst of it. We get the ones that are age-related and age-limited and outgrown and are very much a wonderful thing to be able to reassure parents this will be over by the time she's 12 or 14. And we get the worst, the severe pediatric epilepsies that begin in infancy or early childhood and are refractory to medications and take with them much of the child in terms of the development and cognitive abilities. And I don't know, probably not. Oh, sorry. So why does it happen? There's a number of reasons, and I've listed a bunch here. I think that the familial genetic would be a top part of the list as we learn more and more about genes and chromosomes. Brain malformations are a common cause, and again, you know there's billions of cells and they have to be all lined up and put in the right place and then hook up with their neighbors just right. If they don't, there could be a short circuit and you can have epilepsy. So brain malformations are a high risk for epilepsy and highly associated with it. And those occur either by the blueprint of your genes that say, you know, go there, the wrong gene is telling the cells to go to the wrong place, or they may occur because of something that happens to you in utero while you're developing, maternal infection, exposure to high temperatures, radiation, medications, those things that affect brain development that are external. And then brain injury, infections, meningitis, encephalitis, trauma. There's a certain number of degenerative brain diseases that come along with epilepsy. It's more of a sideshow in terms of the brain has a degenerative process, and then seizures are part of that, as opposed to seizures causing it. Metabolic imbalance, so if your potassium, your sodium, your glucose, any of the metabolites floating around in your bloodstream get really out of range, you can have seizures as a result of it. Hypoglycemia being a big one. And then there's a lot of triggers that are individual. So many, many people with epilepsy will tell you, you know, flickering lights will trigger a seizure for me, or getting stressed out, or tired, run down, anything like that may be putting me in the zone of getting a seizure. So when we get somebody who we are convinced has epilepsy or has had seizures, we do an EEG. This is the brainwave test and consists of putting these electrodes all over the head in an international conventional way, and then recording brain activity, electrical brain activity. And again, this is just the cells that are the ones of action, the neurons. But just to make the point that the neurons are associated with a lot of supporting cells called astrocytes. And the astrocytes are quite active in nurturing the neurons and it's sort of sucking up the chemicals that they use to communicate with each other and kind of pushing the reset button and getting the neurons set and ready to go again. So there's a very busy world in there. Around the outside of this slide, there are some electrical profiles that are taken from an EEG. And the one on the left in the middle, called PDS, is called a paroxysmal depolarizing shift. And that's to say, at a microscopic level, when a seizure is about to happen, neurons in the region that are going to be creating the seizure have this kind of what we call a paroxysmal depolarizing shift. They shift into a different state where they depolarize at a moment's notice. They fire much more rapidly and much more repetitively than they should. And that's sort of thought to be the electrical basis for this synchronization that gets going. Because huge numbers kind of pile into this depolarization shift, and they recruit others at the right rate of firing. This is just an example of what we see for waveforms on an EEG, teased out from the actual EEG. And we have names for them, whether there's 1, 2, 3, 4 per second, 10 per second, and we give it all kinds of names when we read the EEGs. What we're really looking for on the EEG is masses of neurons, masses of cells to be firing synchronously, because even if you're not having a seizure, cells that are used to generating seizures will often fire even in between seizures together, just sort of as a little blip. And what we see is a spike, which is a kind of needle-like sharpness on the electrical recording, which is at the bottom of this slide. And we see spike wave, and the wave part is when the nervous system says stop and puts inhibition against those neurons. The spike is when they're trying to get going. So spike wave is actually a discharge of synchronous neurons and then an inhibitory response on the part of the brain. This is a real EEG on a person, and you can see that we have a little roadmap on the left that's labeled with an odd number, meaning it's on the left side, an even number on the right side, and then the first letter refers to the part of the brain or skull where the EEG electrodes apply: frontopolar, frontal, temporal, central, parietal. Each one of those letters responds to or corresponds to a place on the skull. And then the vertical lines are 1 second apart. At the bottom is the heart rate, EKG. And the black lines are the electricity. And you can sort of pick out pretty easily these spikes. There. The needle-like sharp areas that are spikes. And when we see that on the EEG, it doesn't mean you're having a seizure. It just means that you are predisposed to having seizures because they don't belong there. So in a normal person, we don't see those. In someone with epilepsy, we see those. So the EEG is a very good screening tool to look for and assess risks. If we have a report of an event and we don't know if it was a seizure or not, it can really help say, probably was a seizure. And then we also find that we do record seizures and we record abnormalities. And you can see here, the first couple of seconds on the left are normal. Then you go into a complete spike wave pattern, which is across the board, so it's generalized spike wave. And this is the correlate of absence. So this, after about 4 or 5 seconds of this, the person would be stock still, staring and unresponsive. But not moving. Maybe the eyes might have a little twitching, but otherwise not moving. And that's absence, 3 per second spike wave. Classic pattern. So any questions on EEG or the recording of EEG? So the next part is medications. And so we've determined somebody has epilepsy or has seizure disorder and needs to be treated. And then we've got to deal with this. And they're pretty. They look nice. But and some of them come in liquid. But there's a lot of anti-seizure medications available. And historically, it all began in the 1920s or so when phenobarbital was first discovered. Prior to that, in the 1800s, they used some bromides and some other poisons that were really not very effective. And then phenobarb came along and largely began the era of modern anti-seizure medications. They've been divided into sort of their broad or narrow spectrum as a way of looking at them, which seizure types they might address best. They've also been divided into first and second generation and now third generation based on historical appearance and the experience that we've had with them. And so there's been a story moving from pretty toxic medications that really had effects on bone marrow, liver, and required frequent blood draws, to the more modern ones that are a little smarter in their design and have very little toxicity, but the efficacy still hasn't hit it. In other words, even though we have a lot more medications, there's still a third of people who the medications don't work for. So this is just a way of looking at them in terms of first and second generation, and then some of the newer ones. I put them all in generic, not brand names. So they each have a brand name. Many of them, it's like Kleenex or other things. We refer to the tissue as the brand name because it's so deep in there. Most all of them have gone generic, but the newest ones have about a 10 or 15 year period during which the FDA gives the drug company exclusive rights to manufacture the drug, to give them a chance to make back their investment in discovering it and finding it. So some of them still are only brand name, but I've put them all in generic. So when you go to treat, you really have a lot to choose from, and what we in pediatrics choose first is the least toxic, least harmful, most likely to be effective. And we start with that typically. And then, so it's become more of an issue of side effects and tolerability than it has anything else, because they all work. They wouldn't be approved if they didn't work. But some of them carry with them a little more risk involved with giving them to your child. Cost is an issue, and certainly in the huge numbers of uninsured people and with the actual cost of these medications, that becomes another concern. There's a crisis going on right now about generic versus brand name, and it's such a crisis because in epilepsy it really matters a lot if your med doesn't work for you that normally does, particularly if you've got a job and you're driving and all that stuff. You really can't afford to have a seizure. So it's such an issue that the FDA has put out or the NIH has put out, the National Institute of Health, a study to try to compare brand name versus generic for some of the major anti-seizure meds. It's still a mess because the generic production isn't always the same. So to do a study based on one form of the generic is not going to be generalizable to all the generics. I just want to put a plug in. Pediatric medication trials are virtually non-existent. In 1994, the FDA said children are not little adults and they should be treated and studied with these medicines, which actually are used more in pediatrics than in adults. So there have been a handful of studies that have been done on children with these medications, but most of them have largely not been studied in children, which puts everyone over a barrel in terms of talking about what are the effects on development, what are the effects on a brain that's changing week to week, month to month, and it's largely unknown.
You
So,
can argue the other side of that is that what's going on in your life that cure the seizures,
yeah.
they can't try.
Well, that's why we use the medications, because certainly we know what seizures will do, and so it's probably worth the risk. It's just unfortunate to not have all the information. So if medications fail a third, what else can we do? Because certainly there are other options. And I think the dietary approach is one that has gained great popularity, and it's very useful. It doesn't work for everybody, but then the medicines don't work for everybody either. And the two diets that are out there now are ketogenic diet and legit diet, which is low glycemic index therapy diet. The ketogenic diet was the first one that was really pioneered, and is based on the observation that when children get into a dehydrated, starved state, they don't have very many seizures, children with epilepsy. And so this came from the 1920s. Before phenobarb, they were sort of putting kids in the hospital and starving them into not having seizures. But it wasn't the most civilized way to do things, and kids were miserable. And, it came back as a more sophisticated approach with a little more understanding of nutritional needs and growth needs, etc., so that it includes all those as well. But the basic scheme of the ketogenic diet is to fool your body into thinking it's starving, and because of that, your body will burn whatever fuel is available, and then you make fat available rather than glucose. Normally, your body will choose glucose as the first and easy universal fuel to run on. But if you change your diet so that there's only 10% carbohydrates or glucose, ready-made glucose, and instead give it 60% fat and the rest protein, it will switch over to a different metabolism, and the brain is perfectly happy humming along burning fats. It does fine with that. So the ketogenic diet works probably by changing the acid-base balance in the brain a little bit and making your brain a little acidotic, because when you're burning fat, you're in sort of a dehydrated state, and you tend to run a little low on the base and buffering, and you get acidotic. And it works very well. It's as good as a major medication for people who go on it. It's a lot of work on the part of parents. You've got to really know what you're doing. It's kind of like a diabetic diet, and you have to weigh and measure everything and know what the content is of every little thing that you get in terms of carbohydrates. But if done successfully, it's phenomenally good, and obviously doesn't have the toxicity or side effects, sedating effects of the major anti-seizure meds. The legit diet, low glycemic index therapy, was a branch off from the ketogenic diet, in which people said, well, it's impossible to bring my kid into the hospital and starve her into having these, this changeover. We'd like to do something a little more reasonable. And so it uses complex carbohydrates and gives you a few more of them. So you don't have 10% carbohydrate, you might have 20, 25%. And it's complex carbohydrates that have to be broken down. So you're not taking a candy bar, but you're having, something that's a little bit more bread or something that gets broken down into glucose. And it works pretty well. At Mass General, they have the biggest program for this right now, and they're basically bringing kids in, trying the legit diet first, and if you fail to respond to that adequately, then you move to the keto diet. Because it's a nice way to say, well, if this works, you can stay an outpatient, you can do it from home. And so the legit diet is coming into its own as far as being used quite a bit, and it's a lot easier to work with. Yes?
Is it known how effective either of those diets are for a child who we're not sure if he's having actual seizures, but he's having spikes?
That's a good question. Is it known how effective they are for a child with spikes but no seizures? If you conclude those spikes have meaning, and you think, okay, I want to do something to try something about it, then it would have the same shot of affecting it if it were sort of epilepsy or just electricity as a major anti-seizure med, which is about, 50% of people have a 50% reduction. That's the FDA's definition of efficacy. 50% of people have a 50% or more reduction of their seizures. So I think it would be certainly worth a try. Yeah. So other ways we've approached it, the vagal nerve stimulator. Vagal nerve stimulator is an implanted device that is put over your pectoralis muscle, and then a wire is tunneled under the skin, and a little clasp is put around your left vagus nerve, which is descending from the brain. This little device stimulates the vagus nerve, and it's thought to, we don't really know how it works, but it's thought to propagate inhibition up into the brain and through the basal ganglia, the deep centers of the brain, and then overall kind of quell the situation a little bit. They work pretty well. There's been 30,000 people implanted with them in the United States. They're approved for 12-year-old and up, although we've put them in 3- and 4-month-olds. And they are a nice alternative to medication because there's no remembering to give or take medicine. They work 24/7. We program them from the outside how often to fire. You also have a magnet that you can swipe it with that will give an extra jolt. And for about half of kids, it will stop their seizure dead in its tracks. So it's nice as another way to approach the sort of refractory group. It is a foreign body. It is a device. The battery does wear out and can be replaced in a same-day surgery type of way. Other surgery is the resective brain surgery, where we actually do a craniotomy, take off a part of the bone, and the neurosurgeon gets to work. And if you have a lesion or a part of your brain that is really the generator, and we can identify it, and you've been refractory to meds, that's a good option. And I think that there's more and more earlier and earlier age surgery being done on kids successfully. It's the one of all these things that's a cure as opposed to a treatment. The meds don't cure epilepsy. The vagal nerve stimulator doesn't cure epilepsy. But surgery can in select cases. A couple of other things that are being used, deep brain stimulation and responsive neurostimulation. The DBS, deep brain stimulator, was 2 little probes put into the thalamus part of the brain, deep gray matter of the brain. And again, the same thing as the vagal nerve stimulator, just going into the central area with stimulations programmed from the outside. This was studied in adults in something called the Sante trial, and it did show efficacy, but the FDA has never approved it because there was too little efficacy shown to really warrant all the involvement. The RNS was recently approved, about a year ago. And this is the responsive neurostimulator. Same idea. The little stimulating device is on the outside, but in a pocket in your bones. They kind of cut out a window and stick this thing in, smooth it all over, and the wire goes to the area of the brain where the seizures are coming from. And you cover that area with a little strip of electrodes, and this is programmed. And it's programmed to stimulate as soon as the seizure pattern starts happening in that area of cells. So as soon as the cells start to have that paroxysmal depolarization shift, it's absent and meets fire with fire, and it's remarkably effective in the right candidate. If you can exquisitely localize the seizure onset and put something right over it or right in it, you can use a depth electrode. It can be marvelous and take care of the problem. The problem is localizing that precisely because you're limited to a couple of electrodes only. You can't have a whole bank of them in there. But that's been approved and is available for 18-year-olds now. And then I have a thing down at the bottom about MRI and focal cortical dysplasia, just to make a plug for MRI has really opened a whole new world for epilepsy in terms of cause. And we find that in children with partial onset or partial seizure types that may or may not secondarily generalize, that focal cortical dysplasia, which is an area of brain that is not hooked up right, is not formed right, and is probably a developmental brain malformation, is the most common cause. And those are often surgically amenable. So there's a nice kind of emerging, more sophisticated approach to surgery in parts of the brain that we thought previously we couldn't do surgery on. Status epilepticus is an enduring seizure state, and this is just to sensitize you to the idea that the definition of it has changed. In every major textbook, you open it up and they'll say 30 minutes of seizure activity is status epilepticus. We're calling it 5, and it's not me just calling it 5. The committees across the country are saying 5 minutes because based on really good data, if you're still having a seizure at 5 minutes, statistically, you're likely to still be going at 30, so why wait? 30 minutes, now we're going to treat you. It makes a lot more sense to treat up front and try and prevent status. And in fact, introducing emergent methods of rescue medication have made a huge difference, even in my lifetime. When I started training, we used to have status epilepticus admissions once or twice a week. And this was not just neurology, this was a general hospital. And now it's pretty rare that we see status epilepticus getting all the way into the hospital to the unit because of in the field emergency response that I think parents and other caretakers are the ones who are doing it. And it's been revolutionary to try and prevent this problem, which does carry with it a significant morbidity and mortality. So I'll just move right along there. And just give a plug for Access, the project that we've been working on. It's been a wonderful way of looking at our systems and looking at the systems of care and kind of acknowledging where we have gaps to close and things to do. And I would say that from another venue, which is the Minister of Health from Rwanda, who came to Dartmouth and gave a grand rounds, that I think the notion would be that you do mostly what we need at this point, in that the Minister of Health of Rwanda has taken a system and gone to each village or each community, and they've designated a couple of people as the sort of lay medical experts, and they're able to keep almost all common colds, coughs, things like that there. And then they have a district hospital with nurses, and then they have the central hospital with doctors. They don't need very many doctors. I shouldn't probably be saying this, but they don't even need the doctors because they're able to handle things. And that's because they've empowered the people to know what they're doing and to be able to address things. And I think the model of epilepsy and status and this Access project has really opened my eyes to the idea that we should really have a, kind of community-wide support net for children with epilepsy that begins with people knowing about it, being able to say, what do you do about it, what's first aid for it, and advocate for it. Because if the seizures can be controlled from the emergency situation, that'll go a long way towards getting everybody on board for making these children have better lives. That sounded like a conclusion, but it's not. That sounded like a conclusion, but it's not. So I'm not going to get into the comorbidity, but I want to let you know about this publication. 2 years ago now, the Institute of Medicine put out an incredible book. It's over 500 pages, but it's available as a PDF online. Pardon?
Good nighttime reading.
Great nighttime reading, full of facts and full of a vision of what kind of a world we could create or work to create in terms of systems of care. And I think it's obviously generalizable to more conditions than just epilepsy, but it's a great mandate for how we can look at what we do and where we should put our resources. And this is where the fact about 1 in 26 people will develop epilepsy in their lifetime comes from, which is extraordinary to me. There it is. It's the fourth most common neurological disorder after migraine, stroke, and Alzheimer's. So epilepsy's big, and there's a lot of it. So I'm just going to move to the finish, the finish here. So in 2014, we do have new treatments, new ways to approach epilepsy, and I think that pie chart that showed a third who are refractory to medicines would be addressed by vagal nerve stimulator, by dietary interventions, and you could probably take it down to more like 20% instead of 33%. And we may be entering an era of genetic manipulation. As soon as we understand the basic pathophysiology, suddenly a whole new world of pharmacology opens in terms of getting smart about which receptors and which pores and channels we deal with. And I think that, again, we need to really all work together on this and try to build a system that really will have layers of sophistication and response, but in the field where the seizures happen is where I think is the most important place to start. Okay, thank you very much, and I'll take any questions. Yes? Oh wait, I'm sorry, we have to do the quiz. Sorry. So true or false, 1 in 50 people in the USA will have epilepsy in their lifetime? False. It's 1 in 26. True or false, febrile seizures are a form of epilepsy? False. I did all these false, I don't know. Epilepsy surgery can be done even in infants and young children. True. And there's a high rate of depression and anxiety associated. We didn't get to this. It's true. And then epilepsy is most often genetic. True. Okay. Sorry, you had a question.
So medical marijuana.
Oh, good. Oh, I meant to put a slide about medical marijuana. The most interesting thing going on. Medical marijuana, there's sort of a couple of substances in marijuana. One is THC, and that makes you high, and that's a different thing. What works for epilepsy specifically is CBD. It's a cannabinoid, and there are these cannabinoids that are plant substances that seem to have a remarkable, in our own systems we have what's called endocannabinoids that are our own sort of chemical structures that look like this thing that's the plant material, that have anti-seizure action and potential. In animal models that have gone pretty far, these endocannabinoids or cannabinoids work to alter the excitability and inhibition part of the system balance. In theory, they might be pro-seizure, but in fact, they're anti-seizure. And they're under study in humans in 3 spots in this country, a very limited study, 20, 22 patients per site. One's in Boston, and it's been closed for months. New York, closed for months. Los Angeles, closed for months. They were closed before they even opened because they had long lines of people who had been signed up for it. They are using a product made in England that is cannabinoid, and the results should be out in the next 6 months, at least preliminary results. Along the way, a lot of parents are using it anyway and have found that they are using a strain that comes mainly from Colorado, although I gather Israel has an even better strain that is getting out. And they're very rich in cannabinoids, very low in THC. There's almost no THC, 0.01% or something, so that they aren't going to make your child high. They're given from the product as a pill or a solution. People are also using hemp oil, but I don't think anybody knows what's in it in terms of percentage or numbers, so it's hard to figure out how to dose it. The point is, it's coming, and it's going to be legitimately used in the next, probably I would think in the next year. But at this point right now, it's not available. I talked to the Vermont Marijuana Registry people for an unrelated case, not epilepsy. And I asked her, do you have the strain that's good for epilepsy? And she said, we don't. We don't have access to that strain. No one can bring it from Colorado legally. So the state official dispensaries and state official setups can't get a hold of it officially.
So what is the realm oil that people are getting in Maine then?
The hemp oil that they're getting in Maine, I don't think it comes with any kind of a list of what's in it, but I know at least of one person who's using it with great efficacy. But dosing guidelines I can't provide because I don't know what's in it. And
have you heard about Dr. Holmes' possible trial up in Burlington?
I've heard about Dr. Holmes' possible trial up in Burlington. Again, it's probably going to be trialed in all kinds of places in the next 6 months. But right now the FDA is going, because of the legality and all the other complexity, the FDA is going really carefully and slowly in terms of letting it be just released till it's been studied. And you know, the cynic in me says it's probably going to be great for some, but not a cure-all. Okay, any other questions? Well, thank you for your attention.